sometimes I get to presentations late, and then I'm supposed to do a wrap up, and I don't get to hear everything, but I did get to hear mostly everything today, and I think it was a pretty remarkable set of panels. You guys are very lucky to be in this state and have this set of talent and interest in this issue. And I am going to affirm quite a few things that have already been said, and I also want to suggest that most of what was said today can actually happen. It's all about taking next steps and actually making it happen. And this is from somebody who has been in this now for over 46 years. I started out working for AARP in the early 1970s when I was in my 20s, and I'm now 69 years old, and we're still working on the same issues. And to me, that's a little bit sad. It doesn't mean that things haven't changed. I think they have. I want to speak today, first of all, just to let you know, for those of you who don't know me, I actually live in Washington, D.C. I am not at UMass Boston. I work at Leading Age, which is a national association of aging services providers. Hebrew Senior Life, for example, is one of our members. We actually are currently involved in a new merger with the VNAA, which is the Visiting Nurses Association of America. So some of you who have been part of that will probably also be part of Leading Age within the next few months or 6 months. We have a lot of home and community-based providers in our membership, but my interest is actually very broad in terms of understanding the entire long-term services and supports sector and how it intersects with the healthcare sector. I'm going to talk a little bit about that because I think we do a disservice to home health and home care by always lumping us in the healthcare sector. We actually are the intersection of the healthcare sector and senior living. And it makes us a little bit different. And I think we get lost sometimes in the healthcare sector. I'm actually an advocate for having sectoral work that is done in our sector. This is a tremendous growth area in home care, and I think that I don't want us to be competing with hospitals and other parts of the healthcare sector for staff. I actually want us to be developing our staff and being the first and not the last place for people to make their choices. And my goal in life is to actually flip a lot of the policy discussion that's happening right now on its head. I actually think I have 12 ways that I identified to strengthen the LTSS workforce, and when I talk about the LTS workforce, I'm mostly talking about the home care workforce. And since all of you or most of you are home care providers of some sort, I want us to recognize how important that sector is and that it is a set of professions. And it is very different from a nursing home. It's very different from assisted living. It's actually very different from every other part of the health and senior living sector because it is where people live. It is in the home. It is actually more analogous to what's happening in the gig economy right now. We were just very early adopters of virtual employment. Because now there's all kinds of employment that happens outside of a workplace. But we were the early pioneers in really work that happens outside of a building. And so I think it behooves us to recognize that we have created jobs which are in the frontier of what jobs are going to look like over the next half a century. And we need to be in the lead of that. The second thing I wanted to say was we need to get the word worker and low-wage worker completely out of our lexicon. frontline aides are actually care professionals who are in a career that needs to be acknowledged and adequately reimbursed and adequately identified with competencies, skill sets, knowledge, that then has trajectories in many different arenas for where folks may or may not advance. But these are not low-wage workers. I actually sometimes am upset with some of the advocates, even like the domestic care worker, Aide, who does a lot of advocacy around this. I think this does a disservice to our workforce to actually include them with domestic workers and other kinds of workers who I think deserve adequate pay and benefits, but that's not what we're talking about here. We are talking about a professional class. Go back and look at the competencies that are required for an average home care aide today. Spend a day in a home with an aide. I have spent a lot of days in homes with aides, and my staff has actually set 18 pages of competencies for what an aide does in the home, some of which is often illegal because it's not allowed, because nurses will not delegate, some of which has nothing to do with nursing, has nothing to do with activities of daily living. Somebody else said this. It has a lot to do with understanding the complete gestalt of a home, the family dynamic, the physical environment, the emotional situation, the changes in condition, special problems like comorbidities, medication management, dementia, end of life. These folks are dealing with all of them by themselves in the home. And if you don't think that's a professional job, then I don't know what we're looking at. And to me, the goal has to be to turn this on its head, which means that employers, we are going to have to pay more, which gets me to my first way of strengthening this workforce, which is that Medicare and Medicaid need to recognize that when they reimburse, they are primarily paying for labor. I would imagine that most of your budgets are labor budgets. And the truth of the matter is that when we advocate for reimbursement, we do not directly tie these dollars to what it is paying for. These dollars are paying for those jobs. And when we have inadequate reimbursement, it translates into real challenges for many of our organizations to actually pay legitimate wages. Why we are even talking about a minimum wage with a profession like this is beyond me, but it is a historical fact that this is how it has evolved and it needs to change. But our advocacy at the state level and at the federal level around how we tie these programs and the reimbursement and the training that should be paid for through these programs, not as unfunded mandates on employers or on the direct care professionals, but it needs to be paid for through these programs, just like other professions are paid for through these programs. Why aren't we getting some of that graduate GME money? That's Medicare dollars. And we are using Medicare dollars in many of our organizations, and we need to think about new ways of actually accessing investment in this frontline workforce, because these folks provide 60 to 80% of all the hands-on care in our setting. That's not true for a hospital. We're a very different organization from a hospital. We are very, very heavy on frontline in our sector, frontline professionals. And I think the policy world needs to understand that. So to me, that's one of the first things that I think we need to talk about in terms of what your alliance can do, how you partner with other advocacy organizations at the state level to make it extremely clear that this is not just a gift. We're not talking about a wage pass-through for direct care professionals here. We are talking about adequate reimbursement that recognizes that these dollars have to be adequate to support our operations, but more importantly, to pay the professionals who work in our organizations. And I think that message is not clear, and I don't think policymakers understand it. I can tell you, I've spent a lot of time with a lot of legislators, state legislators, who are completely clueless. I was in a meeting in Utah with about 25 different states on the west of the Mississippi, and a lot of legislators who were from a variety of committees, including budget committees. They had no idea what Medicaid pays for. No idea. And these are the people who are making decisions about how budgets are set at the state level. So the first thing we need to do is to actually think about, on the policy front, how we tie more clearly Medicare and Medicaid reimbursement to workforce development and investment. The second thing is we need to begin to think about workforce indicators in our quality measures. And this is particularly true for the home care arena, because turnover, retention are really strong predictors of quality outcomes. I know, I have done the research. I have done a lot of logistic regressions with turnover rates and vacancy rates, and trust me, they are really strong proxies for quality. If your turnover sucks, you're going to have a high correlation with lower quality outcomes. And somebody was talking about that. I think you were talking about the fact that when you did things around better retention and you saw changes in that, you also saw your star rating go up. It's not surprising. Whether you do qualitative work or whether you do quantitative work, you're going to see the same thing. These measures are really important. I can't stand staffing ratios. I really don't like them in the nursing home setting. Fortunately, we don't have them in home care in the same way. But I think we need to think a lot more about the indicators of a quality workplace and how that ties to quality outcomes. And in the home care setting, this is really tricky because you've got such a virtual workforce. So all of the things that I heard today, which are so phenomenal, peer mentoring programs, creating virtual communities of these professionals, all of the other kinds of workforce improvements that you talked about. I love the idea of these pods where people are actually working as teams. That it's just so phenomenal. These best practices ought to be happening everywhere. And then we need to turn those into formal indicators. How well are we achieving those workplace design improvements in terms of not just recruiting, because I think recruiting gets us into a maze. I think it's mostly about recruiting the right people and retaining and growing the workforce. And if we spent more time on that, we wouldn't be worrying as much about recruitment. And I think you heard that today, but we've seen it in examples across the country of very, very tight labor markets where some agencies and some organizations are able to retain and others are not in exactly the same market. So there's got to be a reason for that, right? It's not just that, they pay better bonuses to get somebody in, because a bonus will only keep somebody, and this has been demonstrated, a bonus will keep somebody for a very short period of time, but you'll see that churning very quickly, because bonuses really don't work. They only work in the short term. They're not a long-term fix for recruiting and retaining a workforce. So really thinking as much, my argument is that we need to think about continuous quality improvement in our agencies in two ways. One is the indicators for the people that we serve, and the other is CQI for the people that are working for us. And those are our two missions as organizations. We are employers, and we care for people. And those are our two major roles in life. And we have to think about, and I love the fact that there was a lot more discussion here about using data, because I think data are really important. Understanding how you actually gather data, how you use dashboards, how you look at how you're improving. I love the example of working with managed care plans. I've been pushing this in discussions with states around the country. I think as the states are pushing out these dollars to manage care plans, we need to be having those plans holding these contracts accountable for who they're hiring in to do this work. And by the way, if they can't find the right people, then the plans need to start investing in training as well. They need to be partners in all of this. And they need to understand that this isn't some magic thing that all of a sudden you do home care and magically it works and you keep people out of a hospital and you give them better quality of care and better quality of life. It happens because of the people. There's no robots doing any of this, and an electronic medical record doesn't do any of this. It's the people who do it. So if we have the right people and we have the right training and we have ongoing in-service, and we have opportunities for lattices, and we have opportunities for career paths. And I love the discussion of thinking outside the box, because if I hear of another apprenticeship of every aide wants to become an LPN, and then they want to become an RN, and for most of them, first of all, it's not even feasible financially. But secondly, as I said, home care aides are really special. They have different skill sets. And the best of them are incredible in relationship development and emotional management. And they lend themselves much more to social work, occupational therapy, management. I love the discussion of thinking about your field staff and how do we build career paths there. Mid-level managers, CEOs of our agencies. I mean, the opportunities are endless, and I think from a workforce development side, we need to also be thinking about what are those pathways, and Leanne I know very well. We actually did the meta-analysis of the PCAS program, so we know a lot about the PCAS program in all 6 states where the PCAS was actually demonstrated, and we were always amazed at how little those programs were actually picked up once the funds died. Massachusetts is actually one of the few that actually incorporated a lot of the PCAS elements into ongoing activity. I also had the privilege a number of years ago of actually evaluating the ECLI program. Were any of you around for ECLI, which was the Extended Care Career Ladder Initiative? Fantastic program in nursing homes and home care. We worked with Senator Montigny. We're going back like 17 years ago, because he cared about these issues and he got money through the legislature to support these efforts, and then when that money died, the efforts died. And the only way that we're going to get sustainability is through 2 things. 3 things probably. One is that Medicare and Medicaid recognize this and build workforce development into reimbursement and into training. The second thing is that we have providers, employers, who actually invest in their staff. Because most of what you do, your turnover rates are because you're doing some really dumb things. It's not because Amazon is around the corner. You're gonna lose people to Amazon, you're gonna lose people to every job, but actually we've looked at the turnover and where people go. Not as many of them are going to flip burgers at McDonald's as you would think. A lot of the churning happens within the field itself. And so it has to do with creating a healthy work environment, which I think is really hard for agencies, because this is a virtual workforce. It's much easier. I don't know how many of you work in nursing homes and how many of you work in assisted living. It's so much easier to work in a building. I always say that the harder jobs are the home care and home health agencies, because they actually have virtual staff. On the other hand, they probably have some of the more creative staff, because people who go into home care are predisposed to be working alone and for the most part, the relationships that they develop in the home. They just need the infrastructure and the supports to allow them to optimize their opportunities to do good. And I think that's how we need to think about it. We've actually been trying to get money from foundations now. We're going on our 5th year, to do some studies of workplace design in the home care sector. What are the ways in which we create healthy workplace environments? And any of you who are interested in working with us, we have a proposal together. We have foundations who keep saying, oh, we don't want to put our money into this. But I think if we actually had some agencies working with us, we could actually get some dollars to get in here and start to help think about what are the best practices for the design of our workplaces? How do we share them? How do we help learn from the examples that you heard here today? And I'm sure all of you have them, from the really teeny things that you do to really full-scale workplace job redesign. The notion of older workers is clearly the case. The average age of a home care worker is 45. A large proportion of home care workers are over the age of 65. And so this is a natural workforce for us, particularly if we can address some of the ergonomic challenges and some of the scheduling challenges and those kinds of things. But I do think older workers, retired workers, people who are looking for second careers, our UMass Gerontology Institute, people who are training people in master's degrees are finding that a lot of the people who are going to that program actually are people who are ready to leave another field. So I think we've got a lot of opportunities for bringing people into our sector, whether it's through entry level or through mid-level management. But we need to figure out how we create attractive work environments for them. I love the idea of having a car. I mean, I do think more relationships with Uber and Lyft. I would say Lyft more than Uber. I don't use Uber. But I think these mechanisms for getting perhaps really deep discounts so that you actually can get staff who really cannot get to work, and it's going to vary depending on where you are and where the aides live. We have a lot of examples of people who have to take 2 or 3 buses to get to work, and that is a real nightmare. That, of course, is a national challenge for the home care sector. And I think as we see new modes of transportation, everybody thinks the autonomous vehicle is going to be the game changer. I'm not sure, and I don't know when autonomous vehicles are going to be happening. But in the meantime, we have other opportunities for thinking about how we make transportation easier for these folks to get to their places. I love the notion of consistency of work. We did a big study on the home care workforce using national data, and one of the variables that actually predicted reduction in turnover and better quality outcomes was consistency of assignment. We already knew that in nursing homes, but it's true in home care as well. These folks don't, I mean, some may. On average, however, aides really want to they have a relationship with people, they want to maintain that relationship, and figuring out how you create consistent assignment through some of these team approaches really makes a lot of sense. I think we need to incorporate competency requirements into new models of care. I don't think we focus enough on competencies and demonstrated competencies, and certainly when I look at the requirements at the state level, many of them are not competency-based, and they need to be. And these are not just competencies in terms of technical skills. These are competencies around the soft skills, because the soft skills are where these folks really, really shine. And this is really where it makes a difference in the quality of life and the quality of care of the people that they're serving. Massachusetts is not a great state for nurse delegation. We have done a lot of analysis of nurse delegation across the country. We also have colleagues who have actually looked at the effects of more flexible nurse delegation on quality outcomes and have found no negative effects whatsoever. Washington State is one of the states that is in the lead. New York has certainly taken major steps in terms of opening up and more flexibility around nurse delegation, with the proviso that nurses are trained to supervise aides in the home. So you can't have nurse delegation without good nursing, which gets me to an adjunct issue that I'm not going to talk a whole lot about today. But as far as I'm concerned, we're not investing enough in nursing in home health and home care. And for all of the workforce development people and the educational people in the room, for the most part, our faculty and our curricula for training nurses in our sector sucks big time. And why, by the way, are people getting they get one little teeny clinical placement in home care? Maybe. Why are they spending all of their time in the hospital? The future is out of the hospital. It is ridiculous. And I can say this because I am not trained in any profession. I'm actually a doctorate in public health. So I am an equal opportunity criticizer of every single guild that is keeping people out of practicing to their highest level that is optimal, and for professional schools that are not training into the 21st century. We, as employers, need to be advocates for this. We cannot accept anymore the fact that most clinical placements are done in the hospital. They need to be done in the community because that's where care is being delivered. And a lot of this needs to happen in home care. Everybody extols the virtue of home care, right? They're all moving to home care. Get the people out of the hospital as fast as possible. Completely avoid skilled nursing facilities, send them all home. And then are we training clinical and managerial staff to actually manage this in a virtual employment environment where when we ask aides who their supervisors are, most of them have no clue. They know their scheduler. They know nothing about their nurse supervisor, and they may see them maybe once a year. I mean, I think we have to be very vocal about this. We have to be talking to our educational institutions around this. It has to be turned around. We need faculty that get what it's like to work in the community. I have friends who started out their careers in community nursing when it was a valiant thing to do. And it seems to somehow have gotten lost in the shuffle, but I think we need to turn it around in the 21st century because this is where the care is being delivered. And when we start moving more into telehealth and using more telecommunications around home care, we're going to need even more competencies at the clinical, managerial, and frontline levels. So expanding apprenticeship programs, I actually think that we should be doing that, but I think as I've said, we need to get out of this track of thinking that the only jobs are entry level, moving to LPNs, moving to RNs. We need to be experimenting with different kinds of on-the-job and pedagogical training. I love the discussion that we had around the Care Academy and these like sort of little mini moment training programs that keep the attention, particularly of younger people, and that use a lot more technology and virtual technology in terms of actually doing the training. I am a fan of the new virtual lab, the virtual reality training for aides. I'm not a fan of it for using with people with dementia because actually the data that are showing that it's actually negative in many ways. It scares the heck out of people with dementia. They lose their gait and it's just, but for aides, we had another demonstration of one of the tools around virtual reality at Leading Age Conference in San Diego a couple weeks ago, and it's a phenomenal tool because aides can really see what it is like to be living in a world with dementia. And once they have that exposure of the opportunities then for empathy and for understanding much more how to actually deal with particularly the non-pharmacologic ways of intervening even with people with advanced dementia. We have so many skill sets around this. We have evidence-based practices that are coming out. I'm on the National Academy of Medicine's committee that is looking at a whole series of evidence-based practices for dementia care. That report is going to come out later this year. And I would suggest that we ought to just use them. I mean, these are actually practices that have been tested in randomized controlled trial. There's really strong evidence behind them. There's no reason to be pulling training out of your ear when we actually have evidence-based practice that we could be using. They're all non-pharmacologic. They have nothing to do with using drugs. So to me, it's really exciting to think about how we develop our staff, how we train our staff, so they can actually be doing the work in the home, communicating with the agencies, sort of the mothership, and really ensuring that we have the best quality of care and the best quality of life for the people that we're serving and for the families as well. I do think that means that we have to become employers of choice in home care, and that will attract people to us. And I do think that the word of mouth, I don't know who was talking about that, but the word of mouth in terms of identifying other folks is even though we've got all these other Craigslist and Indeed and all of those kinds of things, when you look at the ways that recruitment have been most successful, it is actually through word of mouth, through identifying other folks, through quality staff that are working for us now. The other thing that I think is going to loom large in policy is immigration policy. A third of home care workers are immigrants. I don't know what the distribution is here in Massachusetts, but I would bet that in the pockets of Massachusetts, you've got probably that same percentage. But nationally, it's 1 out of 3. It's 1 out of 4 CNAs, but 1 out of 3 home health and home care aides were not born in this country. They tend to be more loyal. Their turnover rates are lower. They tend to be older, which means that they also have more experience. They tend to come from countries that, at least in theory, have revered their elders, and there is a culture of caring with many of these groups that come here to the United States. So the immigrant pipeline is essential for us as we move forward, and I think we need to be paying attention as employers to what's going on in Washington, D.C. around immigration policy, and we need to be weighing in on that as a policy issue, because anything that stops that pipeline, including family reunification, which, by the way, that is how most of our aides come in. They don't come in through visas. They come in through family reunification. Now, Leading Age is actually writing some legislative language about creating some new visa-type models that would actually bring in people who could fit into these aid categories, because we're defining them as professionals, not as unskilled labor. So we're working with some immigration lawyers right now to start playing around with language, and we have a couple of people on the Hill who are interested. But it is a very contentious time in Washington, D.C. in terms of thinking about immigration, and we are an employment sector that is really dependent on immigrants. So it is really in our wheelhouse to be paying attention to this. Finally, I would say redesigning jobs is probably the most important thing for us as employers and for us as workforce development people. I think that is where we can begin to have retention that is meaningful. If we develop training programs that make sense, that are training to competencies, that have not only orientation training, but really good in-service. I can't tell you how many aides we have talked to over the years who laugh at their in-service programs, particularly when you set them in front of a video that they've seen probably 3 years in a row. They don't learn anything. I love the notion, I don't know who was talking about it, about the flexibility of thinking about when you have a teachable moment, when you have a problem with CHF, or you have a problem with something else, that you use that as a moment to actually do your in-service or to design your in-service in a way that meets those needs, because that's what aides really need, is that real-time teachable moment activity. How you do that virtually, I'm not sure, I mean, one of the things that is really important is to get much more feedback from the aides in terms of the challenges that they're having in the home. That is how you actually can begin to develop in-services that mean something. This notion of constantly being in contact with aides in the home, I think, is essential, not only in terms of empowering and making people feel good, but that's the way that you improve care. I would love to see aides every aide have a tablet where they are trained to observe and document. There is quantitative research that has found that in home care, an aide tends to pick up a change in condition 5 days before a nurse, right? And that's not surprising because they're in the home. They see the most subtle changes in a person because they know them so well. And they also can pick up other problems, including a lot of dysfunction in family and potential abuse and a lot of other things that we're not getting out of our aides because they are not included as part of our teams, which actually gets me to my last point. And I just published an article in JAGS, which is the Journal of the American Geriatric Society, on why aides must be included in home-based care teams. They're not some extra person that's in the home. They're actually the major person that's in the home. And I'm working with a set of physicians and nurses in New York who actually have developed some team models for really intensively bringing aides into the team. But that again requires that everybody understands their roles, that aides are trained to do the things that they need to do, and that they have the backup and support from the rest of the system to make sure that it all works. Everybody has to be accountable. I think there's tremendous room for nurses as supervisors in home care. And actually, I think there's tremendous room for aides to become community health workers and coaches. I know we had some discussion of that in the discussion, but why not? Why are we creating a whole new set of community health workers? I mean, aides are indigenous to many of these communities. They are the perfect people to be trained for, as many of them are doing this already. I can tell you from the stuff I see when I do studies in home care, they're doing all kinds of things that would make your skin crawl. And they're doing it because they have to, because their first allegiance is to the people that they care for. And when they see them suffering, and when they see that they need a medication that they are not supposed to be distributing, but that the person doesn't know how to take it, they do it. And they should do it. So I'm going to leave you with that. I have to tell you, this was one of the best home care meetings I've ever been to. I thought the panels were fantastic. I thought the discussion was fantastic. Massachusetts is one of these places that has a lot of stuff in place to actually move forward. And because I'm at UMass Boston, I have an additional incentive to see how things move. So I want to thank you all for giving me this opportunity and also for coming to Sturbridge. The last time I was here was in 1972. I was actually here on the night that Nixon resigned, and we had a huge celebration with a whole lot of overflowing champagne. So I had great memories of Sturbridge, and this is another one. So thank you very much.